Hi, I'm José Gallego. I am the head of the Neurointerventional Department in Alicante, Spain, and I will talk to you about our experience during the first wave of the COVID disease last year. COVID disease is, first of all, an airway infection, but not only an airway infection. We know that in a small percentage of patients, we have a severe deterioration associated with an uncontrolled immune response. That also associates an anomalous inflammatory cascade disbalance, prone to hypercoagulability and thrombus formation that are at the origin of the late cardiovascular complications of these patients. In neurologic deficits appears around 1/3 of the patients, especially we have to focus on stroke problems that are around 6% of the patients in the 10 days after the symptom onset. But we know that even if this is true, the first series from China and from Italy shows a decrease in the number of mechanical thrombectomy we've done during this first wave of the COVID disease. Why are we treating fewer patients? Well, it's probably due to multiple factors. In one hand, we have probably the collapse of the healthcare with saturation of the emergency department, delay of the triage of the patients, no disponibility to move patients from one center to other. And in the other hand, we have also stroke adjustment in each center with restriction of indication, no disponibility of beds for the patients, reallocation of the physicians. In Alicante, we've done also many adjustments during this crest of the wave. We have restrictions on our indication in interventional neuroradiology. We try to treat patients 24 hours a day in hemorrhagic cases. We had also reallocation of some of our physicians. We have problems with beds in stroke units. And we make some changes on our radiological protocol. I will try to explain. In our radiological protocol, the changes were also very significant. We leave one scanner just for COVID suspicion of COVID patients. We take all of these individual protective equipments. We minimize the staff contact with patients, and we extended the angio-CT till the diaphragm just to can review on lung window for detecting parenchymal infiltrations. Specifically in neuroradiology, we use those restrictive in use of individual protective equipment. We take masks for all patients. We leave one of our angio suite for suspections and confirmed patients, protecting it with plastic covers. We minimize the staff contact with the patients. We avoid to leave arterial sheath catheters using compression or vascular closure devices. We move also for a high number of radial access that are easier to facilitate the mobilization of the patient to another primary care center. And we done very few non-intubation patients. We do a controlled orotracheal intubation with just one anesthesiology and one nurse from the intubation and the extubation of the patients, which are the moment of maximum risk. We show here the angio suite with the covers. This is anesthetic management. This was you can see how the anesthetist and the nurse with the protective screen, they do the intubation and extubation alone at the angio suite. And this is our experience. We are a center in Spain. We have a referred population of around 2 million people, and this is our local evolution of the COVID disease. In general practice, if we compare with the year before, we saw a third decrease of our general activity. when we look further in our stroke ischemic cases, we saw that we treat practically the same number of patients, but we have around 1/3 less of stroke activation. The data collected from patient pre and post-alarm state are quite similar. What we saw in times that there is an increase on intra-hospitalized times, probably due to delays associated to the protective measures. And there is also a decrease on the times arising from onset. This is surprising. So we saw why is this possible? Where are those patients coming from? And we saw that in pre-alarm patients came mainly from peripheral centers, but in post-alarm state, most patients come directly from home. That means that we have to think about our organization. We have a drip and ship organization on the region, that patients with the stroke must go first to the local centers and then move it to a comprehensive center. This seems to be not very effectiveness, because the distance between local centers and the comprehensive center is around 1 hour, but the distance from any little village far away in our region directly to the comprehensive center is also 1 hour. So perhaps this is a time for a change, moving from dip to ship to a mothership model. This is a case of ischemic stroke in a COVID patient with infiltration in the lungs. Is a top basilar thrombus. We go from radial aspiration direct, one shot, and everything is all right. What about hemorrhagic cases? We have done the same comparison. We saw that we have treated around the same number of patients with data collected similar in both groups. We saw also the times from hemorrhage, times from onset to hospitalization, onset to diagnostic angiography, onset to treatment, and we saw also how many vasospasms. We've seen an increase in the times from onset to hospitalization, due probably to the collapse of the sanitary system and the difficulties for the patients to be assisted. And we saw an intra-hospitalized times decrease. This is certainly due to the engagement of the unit of Neuroradiology to treat patients 24 hours a day, just to help our colleagues in intensive care to move patients out as soon as possible. This is an example of hemorrhage. Subarachnoid hemorrhage. It was an communicated anterior annulus broken with an A1 aplasia. We put 2 stents and coiling, and what a good result. What about our diagnostic activity, CT and MRI? We saw a decrease in around half of our activity. This is certainly due to the restriction on which patient we treat or not. We only treat emergent cases, and the hospital was completely blocked with COVID disease, and only COVID disease. That makes that the demand of CT and MRI of the brain going down and down. This is an example of thrombosis of the superior sagittal sinus associated with the COVID disease. And this is our take-home or stay-home message. COVID is not only an airway infection. The stroke unit's activity has been altered and seriously altered during the pandemic, but we managed to ensure the assistance in emergent cases. Of course, making some modification on our protocols. And we learn something, that we have to move from the drip to ship model to a mothership model on our stroke care attention. And very important, that teamwork is the key for successful face any challenge in our life. Thank you very much.